we're going to now move on to discuss some practical implications for how to implement a discussion on moral distress among your group of pediatric surgeons and faculty and fellows. I'm joined by Mindy Statter, and we'd like to emphasize that this is a collaborative effort between the APSA Ethics and Wellness Committees, and we're working closely together on this project. So at Seattle Children's, we had a recent moral distress rounds about a patient, and we don't really need to go into the details of the patient, but it was a patient who was a young adult, had relapsed cancer and a bleeding and perforated duodenal ulcer after having had extensive additional abdominal surgery. And there was conflict because the surgical team did not think that further intervention would allow for survival. And the interventional radiology team agreed. The medical team, including the ICU, was sort of caught in the middle. But the family, the parents were pushing to have everything done, and they didn't want to take no for an answer. And it was to the point where the surgical team was asked to operate on the patient, even though the likelihood was that the patient wouldn't make it off the table. So the moral distress there is obvious, and multiple members of our team experienced it, from surgical attendings to our fellows, our residents. And it was something that we were sort of talking about in groups of 2 or 3 in the hallway. And we finally brought it to one of our Tuesday morning academic conferences. And we presented it as a case, and we focused on why this caused moral distress. And we talked about what moral distress is, as you've heard in our previous podcast. But we organized it around some of the core ethical principles. And we defined how those principles related to this patient's case. And it helped me, at least, and I think it helped others, understand why we were experiencing moral distress, and in particular that it's normal to experience the distress as it relates to these core principles. It's not that we're weak or we're not technically skilled or that we're scared to operate, but that this conflict is normal and rational, and anyone would experience it in that situation.
You highlight a really important point, and that's the fact that people were discussing this in groups of 2 or 3, but you realize that moral distress affects a lot of people. And if it's bothering one person, chances are the discussion is going to resonate with many people. And it's an opportunity for people to discuss moral distress within a safe zone and really deconstruct the dilemma as you described, and learn about the ethical principles. And it really helps particularly surgeons in training to get the vocabulary and understand how to parse this out and discuss things freely and identify the ethical principles within a moral dilemma.
Yeah, I think afterwards, most people felt some relief in talking about the case, and they were able to kind of understand why they felt these feelings, that it's normal and that conflict exists and it will exist in patient care, but it kind of helped define why we were experiencing it. It didn't give, any easy answers. I don't think the purpose of these conversations is to say, well, this is what we should do. And, it's not an M&M. So it didn't change the course or the trajectory of the care we were recommending or that we provided, but I think it helped all of us feel better as we continue to take care of this patient.
These moral distress rounds really do help in terms of just pausing and reflecting on your feelings, feeling validated in expressing your feelings, and sharing them in a small group. And it really promotes connectedness and resilience. And again, for the more junior, for the fellows and residents in training, it really does provide them with some structure and a template. So the next time they encounter this situation, they're prepared to have a more structured conversation that may be more balanced, and they don't feel so vulnerable. So they have this context that you provided, the structure that you provided them, which is so helpful.
I agree. And based on Mindy's advice, we opened it up at the end of the session and said, do people have other cases that they want to discuss? And lots of cases came out of the woodwork, and there we experience it, I think, often. And the cases were big and small, not necessarily the really sick patient in the ICU, but all sorts of cases were brought up. And so I think it was a helpful discussion.
It was really interesting that during the pandemic, I'm at Montefiore in the Bronx, and it was the borough that was the hardest hit in New York. And our residents, just like residents everywhere, they were uprooted. They were challenged operationally. They weren't no longer within their normal structure of education. They were forced to change from patient-centered ethics to public health ethics. They were managing patients that weren't really within the standard of care, which really violated their core values. And they saw unprecedented sickness as well as an unprecedented amount of death, which you can see it just ends up causing moral distress and moral residue. So when we had moral distress rounds during the pandemic, it was interesting that we had a few moments of reflection, but then it just an outpouring of emotion and how people felt and how they felt they were struggling with ineptitude because this was a disease they'd never encountered before. All of their algorithms for extubation didn't work. And as soon as they extubated, it seemed like people died. Levels of frustration and anxiety. And the one person that brought up gratitude, because he felt he had lots of friends that were locked down at home, but he had to go to work every day. And he felt this profound purpose and meaning in what he was doing on a day-to-day basis. And even though there was just a few residents that vocalized their feelings, it was very therapeutic for the listeners as well. And they really saw how to convert negative feelings into some positivity that, yes, we can get through this. It fostered resilience. It fostered connectedness, because this was the first time, even though it was all within a Zoom platform, they'd been spread out so far and really hadn't seen each other. So by seeing themselves on a Zoom platform for these moral distress rounds, it was so uplifting to them and promoted a lot of resilience. And they've decided they just want to keep doing this. So we've decided to do this on Thursday nights, the last Thursday of the month, and they provide the case. And it's more relaxed because it's 7:30 at night. So we call it the sip and share rather than moral distress rounds. And a lot of them are home eating dinner, but we've had some really good discussions, and it's growing.
Yeah, I think it's a good thing to have on a serial basis. And even if your program doesn't have it develop into an ongoing series, just devoting a session to talking about what moral distress is for providers, ways to mitigate it, ways to deal with it. I think that's helpful. And I think at the very least, for us, if one of our interns saw that I was presenting a case of moral distress, maybe they would feel that it's okay when they experience it at some point during their training or beyond.
Absolutely. It's validating and for them. And it promotes this connectedness, that they're not alone in feeling this way. The other thing that you brought up is that it can be a lot of gray zone. There may not be answers. However, when you look at ethical dilemmas and a lot of what we experience as moral distress, it's a conflict in communication and a failure of curiosity, sometimes on our part, a lot of the time, to ask why of a patient. Why are they refusing surgery, or why are they requesting this? And at the end, I usually try to say, what are the takeaways here? What are some practical tips? What did we learn from this? What went well? What didn't go well? What are ways that we can deal with a similar situation in the future? And what the residents recommend, I'll usually compile into a synopsis and send it out as an email the next day to all the residents for those that couldn't attend. Just the takeaway practical tips.
I think that's a good summary of a moral distress rounds or a sip and share. And and I think this is a practical way to implement it and to use it at your institutions. So thank you, Mindy.
Thanks, Patrick.